Hi everyone. I thought you guys did a great job in week 7 talking about solutions to address healthcare costs. There were too many to list, but the main ones that I saw were tort reform, caps on medical prices, taxation of hospitals, universal health care, and price transparency. There were some other suggestions as well, but those were kind of the main ones I saw. So some key takeaways that I had this week after I was going through the discussion board, and maybe you've thought about as well. So to me, I saw a lot of you talk about the fact that costs are directly related to the complex system that we have of public-private financing and a lack of regulation on prices. So thus, it would be next to impossible to implement any solution that would directly lower healthcare costs without actually modifying our current system. So that was one thing that came up quite a few times. Another thing that I think was really interesting was that, people talked about the fact that you can implement one or more of the proposed solutions, but if you don't have full buy-in from all of the stakeholders that would need to be involved, then it wouldn't be implemented in a sustainable way. An example of this came up in Group 4. They talked about price transparency and providers posting about how much their services cost. This is all fine and well, but if the insurance companies aren't involved in this, it wouldn't tell the patient how much it would cost to them, given their insurance. So you can know the cost of the procedure, but if you don't know how much the insurance company is going to reimburse for it and what your copayment is or what you're responsible for, then that's not going to help you make your decision. So that was something that I thought was interesting. Another example is the taxation on hospitals. You can implement a policy on, taxing not-for-profit hospitals, but if they're not on board, then there would be significant healthcare lobbying to fight against any proposal that would, put a tax on hospitals. So many of these proposals are not only difficult to implement within the healthcare industry in general, but they also require political will to change. And this is one of the key factors that I hope you take away from this course, that you can have all the data supporting one proposal over another, but if there's no political will for it to change, then it won't. So that was something that came up quite a bit. We also need to be careful when we're using language in healthcare finance, and this is very common. I mean, we could teach a whole course just on healthcare finance. So some of you use charged and reimbursed synonymously, and they're not. One is the price tag on the actual service on the consumer end from the provider, where that's what charged is, whereas reimbursement is what the payer is reimbursing the provider. So example, a Medicare reimbursement. So these amounts could be different, so that's why we can't use them synonymously. So on to week 8 and healthcare workforce and governance. This week we're going to ask ourselves, is there a primary care shortage? What do the data say? How do we best manage healthcare organizations? So let me know if you have any questions on your draft policy analysis due this week, and I hope you had a nice 4th.